busy schedules to join us. If you haven't been on the calls with us in our past monthly eConsult work groups, my name is Libby Sagara, and I work with Blue Path Health. We have a monthly meeting of the eConsult work group, which is comprised of payers, providers, and eConsult stakeholders from California and across the country. We're glad to see this group grow over time and get bigger and more expansive in terms of those interested in eConsult. So we know as we've seen programs grow and we're talking to clinics and providers, especially in California, we hear over and over again right now that providers are being hit hard once again with COVID. So we decided we'd take this month's presentation and really focus once again on what's been learned over the past couple of years in response to COVID-19. We know eConsult is used primarily for routine and non-urgent specialty requests, but we know that it can also be a tool as providers are trying to best manage this influx of patients in response to COVID. So we're pleased to have Dr. Ed Cladera and Jennifer Youngblood today presenting some case examples of eConsult in response to COVID. We are pleased to have our eConsult work group advisors on the call with us every month to share their clinical perspectives in response to what publications we take a look at on a monthly basis. And we're going to have some up-to-the-minute policy updates of what's happening in California with Michelle Canales, Senator Ana Caballero's office, sharing what's happening at the state level in California. And we'll talk a little bit about our annual meeting that's coming up on November 3rd. So thanks again for joining us today. You are all on mute. You are welcome to use the chat to share your thoughts, questions with us. We'll keep monitoring the chat as we go throughout our presentation today. We encourage you to share your thoughts. And it will take a pause after our presentation to allow for some conversation too. So if you're on our distribution list, if you're getting this invitation, you also get our eConsult newsletter. If you're not getting this and you'd like to receive it on a monthly basis, please do let me know, and we will make sure to get you on our list. One really interesting presentation we saw this month, or publication, I should say, was in Health Affairs. Not a particular shout out to eConsult as much as just something that we're all aware of throughout this pandemic, that we need to be listening to primary care providers' needs. That's what we're talking about COVID today. But this presentation was particularly relevant, noting that what we've learned and what we've known throughout the pandemic, that patients presenting in clinics, those who may have been exposed to COVID, do increase risks of other patients getting COVID. So this was really eye-opening, that actually measured the exposure of patients sitting in waiting rooms to others that may have had COVID, and that those patients, when exposed, obviously have a higher likelihood of coming back and presenting with COVID. So just makes us think a little bit more about how eConsult can be used in response to those patients' needs, those who may have COVID, and managing their care. So we'll hear a little bit about that today. And with that, I'm going to hand it over to Dr. Cladera and Jen, who are going to share some examples of what they've seen. And I think these are really great and specific COVID examples. So Ed and Jen, would you like to introduce yourselves and go ahead and get started?
Absolutely. Thank you again for having us, Libby, and thank you to the audience for listening. Pleasure to present on high-quality eConsult solutions, delivering timely access to COVID care guidance. Next slide, please. Jen?
Yeah. Hi, I'm Jen Youngblood. I'm here at Arista MD. And at this point, we really don't know when or if our healthcare systems are really going to return back to pre-pandemic norms. However, what we do know is that COVID-19 has interrupted our traditional healthcare. The National Opinion Research Center at University of Chicago, also known as the NORC, collected statistics from 2020 that demonstrated the extent of the interruption in our healthcare. So what we have here is some statistics. We know that 39% of elderly adults canceled or delayed elective procedures and treatments, 32% canceled a primary care visit, 15% canceled an essential treatment, and more than 55% of adults 70 or older have had disruptions in their care since COVID-19 was declared a pandemic. Total visits to the hospitals nationwide have declined 32 to 60% compared to their pre-COVID numbers. Next slide. So what we do know is that telehealth disease management tools, and specifically eConsults, are already increasing patient health and safety. So the benefits of eConsult platform are that both acute and chronic disease patients can still receive safe and efficient access to that specialty care, even when they're under their stay-at-home orders. And the continuity, they can continue to get essential specialty care. We can keep lower acuity patients from becoming higher acuity patients due to delaying care and extending specialty capacity. So simply put, delays in medical care are bad for our health and the health of our population and the organizations that provide care. So that's one reason that in the area of COVID-19, medical professionals and healthcare organizations are adopting telehealth disease management tools at an extraordinary rate. So what we'd like to do next is take a look at some of those examples, and I'll hand it back to Dr. Cladera.
Thanks, Jen. My name is Ed Cladera. I'm the medical director at AristMD. And the first case I'm going to present to you is a very common case that we've been seeing on e-consults at AristMD, and it is the post-infection, post-hospitalization question that a primary care provider has for one of our specialists. This specialist particularly is a pulmonologist. And the chief complaint is a chronic respiratory failure. This is a patient whose status post-hospitalization, history of acute and chronic respiratory failure with hypoxia after COVID-19 pneumonia, requiring increased supplemental oxygen. The chest X-ray demonstrated bilateral infiltrates. The patient's on 4 liters of nasal cannula at home, and the primary care provider is wondering, how are we going to taper this or wean the patient off of oxygen? The main question, 68-year-old male, COVID-19 pneumonia, now requiring supplemental oxygen after infection. Next slide, please. The pulmonologist is able to confirm and reiterate the query to make sure both are on the same page. A patient currently discharged on 4 liters of nasal cannula. 10 days ago, saturation was relatively reasonable on that 4 liters. The pulmonologist notes the medications, also notes the antibiotic regimen at the hospital setting, and also the plan to taper the steroid treatment. The pulmonologist is able to offer the reassurance to the primary care provider. Mostly supportive treatment is being offered to this patient, and the pulmonologist is also able to give further direction, such as in addition of the steroid taper, oral steroid taper, to add inhaled steroid medications such as Advair or Symbicort to the patient's medical regimen. The pulmonologist is also able to give further guidance and suggest that in 3 to 4 weeks, a chest X-ray would be recommended, and also pulmonary function tests in 2 to 3 months. Final recommendation was just to provide supplemental oxygen to maintain greater than 90% O2 saturation. This is a very common question, a dynamic that we're seeing from the primary care providers and their post-COVID patients. Next slide, please. This is a good example of a cardiology question that a primary care provider has. A specific chief complaint is chest pain. The primary care provider gives it in a 1-week block and a 2-week block history. Patient is post-COVID infection like the earlier patient, presents secondary to an asthma exacerbation. The primary care provider is on the right track. The primary care provider is going to get an EKG, a D-dimer to rule out the pulmonary embolism, and is also considering obtaining a stress echo if the shortness of breath or the chest pain does not resolve with a steroid burst. On week 2, the primary care provider is able to tell the specialist there's continued chest pain, complaints of tightness, no chest pain, but feels that it's radiating more to the back. D-dimer and CBC in the meantime has been negative. The patient is going to follow up with an EKG at the primary care doctor's office, and the PCP is considering obtaining a CT for evaluation of the aorta, lungs. CTA and chest X-ray has been ordered. The PCP is asking for further workup and treatment recommendations. Next slide, please.
Dr. Cladera, can I take just a pause really quickly? And
absolutely.
Well, actually, I'm sorry. I'll ask the question. Let me let you present this response, and then I'll ask my question. Sorry to interrupt. Go ahead.
No worries. So the cardiologist is able to give treatment options available at the primary care level setting. The cardiologist had the opportunity to review the EKG that the primary care provider had obtained of the patient at the primary care provider's office. The EKG was normal. The cardiologist is able to suggest that the symptoms that the patient is experiencing may be mostly pulmonic in nature, and agrees with the primary care provider that further studies would be indicated in this particular case to rule out pulmonary fibrosis post-COVID infection with the CT and chest X-ray. The cardiologist is also recommending obtaining an echo to assess for further cardiomyopathy post-COVID. We've seen some cardiomyopathy and also pericarditis, even pericardial effusions. One caveat, the cardiologist is able to tailor the primary care provider's recommendations such that a stress echo or stress test would be relevant only if all the above testing is unremarkable. And just as to reiterate, the primary care provider was thinking about a stress test, but the cardiologist is just reinforcing that. Let's make sure that everything else is negative in order to move forward to any stress test to make sure that there's not a cardiac process ongoing here. Libby, did you have that question?
Yeah. Since I'm not a clinician, you can correct me here, but it seems like these questions are fairly serious. You know, the primary care provider may need some pretty quick turnaround on response to these concerns. Do you feel like in these cases, is this something that's pretty common, these types of questions? Are these more acute than the typical questions that you see?
Good question, Libby. We've been, and you're accurate in stating that the first example and the second example are patients that not only have comorbidities, but are experiencing symptomatology. And fortunately, although a RiskMD has a service-linked agreement with their clients of 24 hours, the majority of our specialists are able to give a response within 4 to 6 hours. So our turnaround time is really good. So a patient that's being seen by a primary care provider in the morning reaches out to a RiskMD via an e-consult, we typically have an answer back before the end of the day. This is a very good example, though, of the type of questions that we're seeing from our primary care providers. Patients that have been hospitalized with ongoing symptomatology even after discharge, oftentimes requiring reassurance and a little bit of direction or guidance in the post-infectious state.
That makes sense. So it's not emergent, but it's just managing the patient after discharge. Thank you.
My pleasure. The third example is also a post-COVID infectious state, more streamlined, more reassurance. And this is a pulmonologist answering. The primary care provider is asking, patient had a CT scan in the ER due to COVID with shortness of breath. The CT demonstrated a multifocal patchy ground glass opacification. That's a fancy way of saying, looks like the patient has COVID pneumonia. Do we need to repeat imaging? If so, an X-ray or is a CT required? So this is a primary care provider that knows that this patient has COVID pneumonia, but is uncertain depending on the findings on the CT that the patient had on the ER. What's the next step to take? What type of follow-up imaging? Next slide, please. The pulmonologist is able to give some reassurance. Patchy ground glass infiltrates can be seen with a COVID-19 infection, COVID-19 pneumonia. As long as the patient is clinically improving, it should resolve. And oftentimes what we do see is that radiographic imaging that demonstrates underlying pathology does require a little bit longer time to resolve as the patient continues to improve. However, the location of those findings on this particular patient was concerning or did raise a differential diagnosis for a non-specific interstitial pneumonitis. And so the pulmonologist is recommending a repeat CT of the chest in 8 to 12 weeks after clinical improvements, just to confirm that there's resolution and the patient's on the right track. The pulmonologist is also able to recommend, if unfortunately the patient does continue to have CT radiographic findings at 8 to 12 weeks out, further investigation or evaluation is warranted at that time. Thanks, Libby, for having us present. I'll see if you have any questions or if anyone else, depending on how you want to format.
Yes, so I'll start with a question. So some of these, or it seems like a trend in these questions was that they were for post-COVID patients who, need some ongoing management, and really there is not a lot of, primary care providers may not have a lot of background on how to manage a patient like this, since this is, unforeseen pandemic, and we haven't had this experience in the past. So are you seeing other types of use of e-consults, say, for patients who need a different type of specialty care, maybe haven't even they maybe not have been hospitalized, but may have had a mild COVID case, but need other types of specialty care? Are you seeing other cases or other sort of use cases of e-consults besides just post-discharge?
Absolutely, and thank you for asking. A few other e-consults that Jennifer had me screen for our presentation that did not meet the cut were for infectious diseases. The primary care providers were asking, as you may know, COVID vaccination is oftentimes a two-step process. First vaccination, maybe 3 or 4 weeks later, you'll get the second vaccination. And a lot of the primary care providers were asking if a patient had symptomatology after the first vaccination, would they recommend the subsequent vaccination? Is it safe? Is it appropriate? And so a lot of these e-consults were being forwarded to our infectious disease expert panel on our service.
Thanks, Dr. Clitter. And I'm waiting for questions that come in via chat. And also, I'd be happy if anyone would like to unmute themselves. As you know, you're all on mute. But one more question for Dr. Clitter in meantime. Are you seeing questions come in from providers? We've heard this around the Central Valley in California. We have vaccine hesitancy, and it's across the country, of course. So do you see questions from primary care providers around, my patient is hesitant to become vaccinated, what should I do? Do you get those kinds of questions?
Good question. I'm going to see if Jennifer, would you like to take this question?
Yeah, I haven't really seen a lot of e-consults where they're asking the question about patient hesitancy or refusal. We've had some that have asked about family members having specific reactions, and maybe there's concern that way, or if they've had a previous illness of a different kind, are they still capable of receiving the vaccine due to the secondary, having the previous illness. So those are the kinds, but I have not seen much come through in just the way of my patient really is hesitant because of this, what do I do?
That's really helpful, Jen, because I'm sure a lot of those questions sort of have standard responses and, in terms of the process of getting a vaccination. So that's great to hear it can be used in that way too. I welcome our group to unmute if you have a question for Jen or for Dr. Cladera. Or if you're shy and don't want to ask that question, you can share it in chat. Delphine, did you have a question?
Yeah, I did. Thank you for sharing. In our system, we have had numerous questions from our primary care providers about rehab for patients with sort of long haul COVID and maybe mental health resources. And I'm curious that in the area. And I'm curious whether you guys have received any of those types of e-consults as well, and how you are redirecting, how your e-consultants are redirecting those PCPs.
Good question, and thank you for your question. Jen, I'm going to ask you, in the preparation for our PowerPoint presentation with Libby, did you come across cases where the primary care provider had a patient with COVID or post-COVID with behavioral health queries as well?
I have not seen that and did not come across it during this look for post-COVID questions, but that does raise a very intriguing thought that, we looked and keyed in specific areas, so it doesn't mean it hasn't come through. It just means it did not really bubble up to the top.
Good question.
Delphine,
anecdotal. Sorry to interrupt.
Sorry to interrupt. Delphine, this is Paul Givney from LA. I was gonna respond to your question on behalf of what we've experienced, but I can save that.
Oh, please share.
With regards to past or long COVID kind of symptoms, we've also been trying to track that in Los Angeles, and what we found is that there's a number of patients that kind of have a single symptom, and so we've been sending them straight to like our mental health e-consult portal, or pulmonary or cardiology or for whatever it is. But we've noticed that there are a number of patients that kind of have a constellation of symptoms, multifactorial. They have maybe some brain fog, maybe some fatigue, maybe some shortness of breath, maybe some palpitations, and they're a little bit more complicated. And so actually, we're getting ready to launch a new e-consult portal for those patients that are a little bit more severe or complicated, to connect them with either if it's pulmonary rehab or if it's mental health, and we're trying to route them to providers in our system that have kind of an interest, an academic interest or a clinical interest in the treatment of past or long COVID. And so we have not yet launched that portal. We're going to kind of probably make a final decision to do that tomorrow at a meeting. But anyway, I wanted to let you know that we're starting to see some of that and trying to figure out ways to route it, especially when the symptoms are multifactorial.
Yeah, that's super interesting, Paul. I think our pulmonary folks were the ones that wanted to keep taking those e-consults within our system because they felt like they were the best suited to help redirect when needed. But I'd be interested to hear your experience in the next couple of months, and we might consider, changing our model as well, depending on best practices elsewhere. I think another piece that our pulmonologists have really tried to do is on the e-consult page with the list of best practices and recommended tests and diagnostics. There's also some references that they have for patients and for providers that they particularly like. So for example, they really like this website from Johns Hopkins that's related to sort of rehab exercises that patients can do at home. So that's sort of front and center as a recommendation for the primary care providers to talk about with their patients while they wait for a pulmonary rehab appointment or pulmonary appointment or something like that.
Thank you. And I'm just going to pause here. Dr. Cordero, please stay on and join in this conversation. I've brought on our clinical advisors, Delphine Tuo with Zuckerberg SF General, and Paul Givney, who is with LA Department of Health Services, is not on video, but probably because he's treating patients. And I also want to welcome Greg Bucher. Greg, I'm going to have you introduce yourself, and I have a question for you. You bring in a different perspective, having a deep leadership of health plans. And maybe you can share just when you're listening to this in terms of clinical responses to COVID cases, how might you think, how are plans taking this information and trying to figure out how to best serve their patients and members' needs? And what might you advise plans in terms of working this into their approach? Oh, and Greg, you're on mute. Let's make sure you're unmuted here.
How about now?
Good.
Okay. Well, I think the first thing is, some of the literature you're presenting suggests that, when people go to the physician's office, they're more likely to get infected and get exposed to those who are sick. And so there is an increased emphasis on trying to promote e-consults. And what a plan can do is, number one is they have to pay for it. And obviously paying the specialist, but as we've talked about in these forums, paying PCPs as well would be something to promote the use of e-consults. And then it's looking at how they contract with their providers, because most of this activity is going to occur at the medical group or individual provider level, and it's going to depend on what kind of contracts they have. In the fee-for-service world, where the plans contract directly with the providers, I think two things they can do is, number one is educate and market the availability of e-consult once they're paying for it, and the second thing is to actually potentially require it that an e-consult is required before a face-to-face visit with with the specialist. So those are some things that can happen on the fee-for-service side. It gets a little bit more complicated, and in areas like California, where we've got a plethora of capitated delegated medical groups and IPAs. And there, what the plans can do is actually make it a contract requirement that the medical groups, IPAs, provide e-consult availability. And once that's there, to then engage in extensive marketing promotion of e-consult and providing a lot of the literature that suggests the value of e-consult to hopefully recruit buy-in by the primary care providers.
Thanks, Greg. That's really helpful. I mean, the same message is hitting home, and thank you for emphasizing just the financial support that plans are putting out right now for e-consult. I know that there are many plans who are supporting these programs, so thanks again. And Delphine, maybe you can elaborate on that. Just you've been doing this for, I don't know, 10 years or however long you've been doing e-consult, and it's been a major part of your approach to specialty care across both Zuckerberg, SF General, and UCSF. Is your approach to e-consult as a health system incorporated e-consult into the approach, or is that a consideration in terms of how you address the COVID needs in San Francisco?
Yeah, I think that's, yes, but I will say we've incorporated, e-consult is just part of the way that we provide routine specialty care. And it's really the first stop in trying to decide what's the best way that we can provide the patient with the needs that he or she has. So I would not say that our approach has changed, but I do think referring providers have also become more in tune that maybe they can do a little bit more with e-consult than maybe they thought previously. And I think many e-consults are now moving towards the specialist saying maybe, oh yes, in this case, they should get they should get face-to-face specialty care, but maybe that's not face-to-face in an office visit, maybe that's face-to-face virtual, right? And so I think that's where we've seen a little bit more of the shift in our system as opposed to more e-consults. So I think everybody is trying to use virtual care delivery as much as possible and as safely as possible. And clearly that includes, but is not limited to e-consults.
That's really helpful. Thanks, Delphine. And I know, Paul, you may or may not be with us since I know you're probably running from place to place, but maybe you have some thoughts since your approach across LA has been incorporated e-consult as the first step to a specialty referral, and I'm sure as a result of more than a year of COVID, there's probably an increased backlog in specialty referral requests. Do you have any thoughts on just has this affected your approach to e-consult, or has anything changed over the past couple of years and throughout the pandemic?
Yeah, I'm still here. Thank you. It is, looking back on the last 18, 19 months now, I can't even imagine what we would have done without e-consult. Because of the ability to really understand a patient's specialty needs before they arrive, it allowed us to understand what was the best modality for the patient. With the move at the beginning of the pandemic to a lot of phone and video visits, it allowed the specialist to determine, if the patient could stay with the primary care doctor, but also if the patient needed to come for an assessment with the specialist, could that be accomplished by phone or video instead of in person? Also, in the various surges and phases of the pandemic, our capacity within our hospital facilities varied, right? We sometimes would have to redeploy nurses into our ICUs or critical care units, or the ERs were full or whatever it was. And so knowing kind of what the patient needed also allowed us to determine the best location. So maybe normally a patient might go to one of our big acute care hospitals, but instead, during the pandemic, if we needed to see them in person, maybe we would have them be seen by a specialist at one of our ambulatory outpatient centers. Things like that was really, really important. Of course, timeliness. What is the right time frame? Can it wait? Can it not wait? And so, we did see during various surges, especially, an accumulation of a backlog, so to speak. We always, because of e-consult, we were always able to deal with the most pressing matters initially. But sometimes we would say, okay, we're going to wait to see this. But the data tools within eConsult helped us keep track of that. And over the last couple months, during the summer, start to really exert more attention on those areas that we could see in the system that we were still needing to catch up on. Now that we're in yet another surge, we're redeploying all those tools again. And so I don't even know how systems without eConsult do this kind of stuff in a smart, intelligent, and patient-centric sort of way. I can't even picture it anymore. But what we're also trying to do is use the information from eConsult, and when necessary, even identify partners that are outside of our network to route patients to if we just flat out don't have the bandwidth or the capacity to do so within our current resources. So there's been a couple of different strategies that eConsult has helped us do it with regards to backlog. And, you know, are we completely done with our backlog in the face of a fourth surge? Absolutely not. We're still working in select areas, but the tools available really helped us have confidence that patients weren't just being ignored, that we were still triaging them appropriately, that we were still attending to urgency and timeliness as needed. I hope that answers your question.
That was great, Paul. And I have a question coming in. Thank you always for your thoughts on this. I know it's great to have this as sort of a standard piece of your referral process to be able to see how this has impacted your care over time. A question came in for Delphine. I think it's relevant to you all, but I'm going to read it really quickly. Delphine, I'll let you verbally respond since I think it's interesting for those who can't see the chat. So have you seen in your health system an overall increase in behavioral health needs, given that COVID can potentially affect patients' mental and well-being, regardless of COVID infection status? Go ahead, Delphine.
Yes, I mean, I don't direct the mental health services within San Francisco, so I can't provide hard data for you right now, but we have certainly seen an increase in behavioral health needs within our primary care settings and within our specialty care settings as well. And so I have seen that come across from a lot of the e-consults, as well as our direct referrals to specialty care mental health. And so we've been trying to meet that need to the best of our ability. And some of that has come directly from COVID infections, but a lot of it has actually come from the isolation resulting from the pandemic that I think we can all appreciate.
And this really dovetails into our next topic. I'm not going to take this off yet, but we'll be talking a little bit about policy and state acknowledgement of the need for telehealth for behavioral health. We'll talk about that in a moment. But before we move on, Greg, I just want to see if you had any closing thoughts on just what we should be thinking about in terms of incorporating eConsult into responding to clinic COVID needs. And you're on mute, Greg, sorry.
Okay, now?
Yes.
Okay. One of the things we haven't really talked about is the fact that with COVID, it really has impacted the supply of physicians. That if you've got physicians that are typically seeing patients in a clinical office setting, and all of a sudden they have to isolate, and as we have kids going back to school, then there's parents that are now having to isolate, and you see the staffing decrease pretty dramatically in some settings. eConsults allows those individuals, those physicians, to continue practicing and providing value when they're at home that they wouldn't be able to otherwise. And so there's really that bonus of having eConsult as an option that can really bring that workforce back to work.
Sorry, I muted myself. That's just a great reminder, Greg, that as we talk to clinics who are incorporating eConsult into their processes, and it's taking some time, there are a lot of distractions right now across the country, not just COVID, but fire, storms, everything else that's pulling our clinicians away from their workplace. They do need additional tools and support. So thanks so much for sharing that thought too. We're going to move on, and I want you as clinical advisors to pipe in this next couple of slides as we discuss policy, because we're seeing some exciting news out in California. We hope this can be model language and movement for other states who are joining us in these discussions. So thank you, Paul, Greg, Delphine, thank you, Ed and Jennifer too, for your contributions. It's been great to see these specific examples. And I'm going to hand off with some exciting news from Michelle Canales' office of Senator Ana Caballero's office, along with Robbie Franceschini with Blue Path Health. And I just want to take just a moment to thank our sponsors of the eConsult Workgroup who make it possible for us to work together to address policy needs and educate state leaders on what we've learned around eConsult and its benefit to our patients. So Michelle, thanks for joining us once again.
Yeah, thank you so much. My name is Michelle Canales. I work for Senator Ana Caballero, representing Senate District 12, and she is the author of SB 365 on eConsults. The bill would require Medi-Cal to reimburse for eConsults for all primary care providers, and actually for anybody initiating the eConsult at the original site. And we wanted to expand this to include providers operating out of an FQHC or an RHC. The bill was heard this morning in Assembly Appropriations. It was placed on the suspense file because of the cost, and we learned it did get off, which is really great news. Next, we head to the Assembly floor. We will have to take the bill up for a vote before September 10th. That is the last day to do so, and then it will head to the governor's desk. So I wanted to thank everybody who has signed on in support of this bill. It's a huge achievement. We're really close to the finish line. And also ask if you are interested in coming on in support. We still have to get through the governor's office, and anybody willing to sign a letter of support, we'd be grateful and very appreciative. But thank you so much for the work that you do. This is a really good step forward.
Thank you, Michelle, and thanks for all the work you've done. I'm going to step back a slide, and I'm going to ask Robbie Franceschini with Blue Path Health to share some other policy updates. Back to the need for mental health and telehealth support. Go ahead, Robbie. I think you're on with us, Robbie. If you're not, then we will move on. So just an acknowledgement that we know that mental health needs, as we've discussed in our panel, are becoming more and more apparent. So we are seeing some movement, not just in California, but across the country in terms of support specifically for telehealth, and with an even greater focus on telehealth for peds. So we're glad to see this. We're also seeing alignment of various telehealth and eConsult programs, making them work together, giving providers options to do both phone and eConsult. So we're glad to see this, along with ongoing support and the maintenance of temporary flexibilities that providers had during COVID to continue the care that they've been delivering. I'm not sure if Delphine and Greg have any comments on what they're seeing at the state level, or any ongoing policy observations.
I do not have anything additional to add.
Thanks so much.
I've got nothing to add.
Thank you, Greg. We are glad to see other states join us, and we'll keep monitoring what's happening across the country. We know folks from Colorado and New York have been active participants in our calls, and we'll hear from them next month in terms of what's happening in their states. So with that, just wanted to put on your calendars that we have our annual meeting November 3rd coming up. We were so excited to meet again in person. This has been happening for 6 years now, and we've been able to meet with many of you on an ongoing basis and hear how your programs are progressing. We are sad. This is a hard time for us all. We wish we were able to meet with you all in person, but that's not possible with our current state. So we're doing this once again virtually. The good thing about virtual is that you, as busy people, can pop on and off of a Zoom. You don't have to travel. You don't have to be in a situation that may be uncomfortable or unsafe during COVID. So we're glad to do this once again virtually, and thank our sponsors for making this happen. So please save the date. We'll get an invitation out to you in the next month for our event. And many of you enjoy speaking about your programs and sharing the progress that you've made. So we want to hear from you. So just putting this up on your screen here, you have this in your email. in our monthly newsletter a link to our annual meeting survey. So if you want to take a moment, if you have providers, payer leaders, policy leaders who would like to speak about the work that they've done in the past year, you can click this link and you can submit a recommendation for a speaker or a topic for our work group. If you are one of those people that you know that you get way too many surveys and you don't want to respond to our survey, you can share in the chat. Please go ahead and type it if you have any ideas of what you'd like to share with us. And some of the questions that we're asking are very simple. This survey you could probably do in 2 minutes. Just what topics do you want us to focus on? We want to make sure that this is lively and dynamic and interesting to you all and relevant. And we do want to just keep hacking away at our challenges that we see and that we're working on as a group. We appreciate all of your examples of how to tackle these problems, or just to maybe model programs that are effective, such as primary care provider reimbursement or incentives, addressing workflow challenges, working with vendors. We have great vendor support. Thank you all who are on the phone today. Addressing issues around integration, or perhaps the programs that work without any sort of integration. Looking at our payer support and modeling after effective programs that we've seen, our regional community efforts, and continuing to address these policy needs. And thanks, Michelle, for all the work that you've done. So you can click on this link. And thanks again for sharing your thoughts and making this a meaningful event for us all. And this is another opportunity if you would like to hear, we've heard of the importance of payer support for these programs. This is happening in the next just an hour. If you have a moment and you want to listen in and get some updates on what's happening in our payer supported programs out in California, we're so pleased to see these programs grow between Anthem, California Health and Wellness, and HealthNet collaborating to grow eConsult across their regions. So there's a presentation today at 2 p.m. if you'd like to attend the CTRC Summit. It's a quick registration process if you'd like to join in. And we're pleased to say that after we've seen eConsult grow across the Central Valley, we're seeing the same sort of program modeled after the Central Valley growing up in the North State. So this is called the North Rural eConsult Coalition. And so we'll follow these programs and share what we see in terms of eConsult utilization and growth. So lastly, just as you know, you can visit econsultworkgroup.com for these recordings, for all of the publications that we share on our monthly calls, and a playbook which highlights all the programs that we hear of on a monthly basis. And whoops, there we go. So I'm going to wrap up early today. I appreciate your time and we look forward to seeing you next month. And thank you again.